Okay, good afternoon, everyone. Welcome to this webinar, which is all about supporting people with comorbid physical, mental health and substance use problems. I'm Colin Drummond. I'm Professor of Addiction Psychiatry at King's College London. I'm also the Director of the Mental Health Implementation Network, which is hosting this webinar. And I'm also one of the two leads for this project, which is the evaluation and implementation of alcohol assertive outreach treatment. So we have an excellent group of speakers going to speak to you this afternoon. I'll introduce them as they come up. I have a few housekeeping things just to note. The event will be recorded, and we need you to agree whether it will be available to delegates for people that missed the event. The aim is to put it up on our ARC South London YouTube channel. For questions and answers, you'll be able to do that. If you look at the bottom of your screen, there's a question and answer function. So if you want to pose a question at any point during the webinar, please put it in there. If it's something we can answer straight away, then we will. If not, we'll probably keep it till the question and answer session at the end of the session. You can also use the chat function if you just want to make comments, but we'd prefer if you keep all the question and answer into the Q&A section. When you put a question in there, it'd be good if you could say who you are and what organisation you represent, just so we understand where you're coming from. It is also possible to vote on the questions within the Q&A function. If you go in, you'll see how to do that. Also, if you need to, you can enable closed captioning using the options bar to do that. If you need any technical support during the event, please contact one of the team on the emails provided in the chat, which should come up in a few seconds. So I think Michelle's going to put the email address there. And if you use Twitter or X, please feel free to tweet about the event and use the handle that we're going to put up in the chat section. Just to be inclusive this afternoon, if you could please avoid using acronyms where possible. If you need to discuss an acronym, then spell it out, please. And also, please be respectful to each other and allow room for constructive challenge. Our break will be at 3:45, and you can go off and have a virtual cup of tea and come back and join us for the final sessions. Okay, so I think without any more ado, I should introduce our first speaker this afternoon, who is Amy Wolstenholme, who is a Programme Research Manager at King's College London and also a PhD student, and her work has been on evaluating alcohol assertive outreach treatment. So I'm going to hand over to Amy. Thank you.
Thanks, Colin. I'll just do the necessary. Can you see my presentation?
Yep, all good.
Great. Okay, well, thank you very much for inviting me to speak. As Colin said, I'm Amy Wolstenholme. I'm a PhD student at King's College London at the moment, and I undertook an economic and qualitative evaluation of assertive outreach for alcohol patients. So I'm going to take you through some of that, but also to provide an overall context and background for the afternoon's events, for the very interesting presentations that are coming up later. So first of all, I'll give you a background on alcohol assertive outreach treatment. I'll provide you with information from our trial, which took place in South London, and I'll just give you a little bit as well about what the patients thought about it. I think I'll be skipping as fast as I can without speaking too fast. So forgive me if I do skip over anything. I think the slides are going to be shared afterwards, or I'm very happy to take questions. So obviously we know about the harm that alcohol causes societally and to health. It's the third leading cause of disability in Europe, and the prevalence in England at the moment of alcohol dependence is 1.6 million people. There were 7,556 deaths wholly caused by alcohol in 2021, and many more partially caused by. And that's all within the context of a reducing number of people accessing treatment who should be. The estimates at the moment are between 6 and 20% of the in-need population accessing treatment in the community. So I think you'll agree that's fairly low. And that is also with the context of where services have moved since the Health and Social Care Act in 2012. Addiction services moved into local authority public health remit. And of course, we all know about the cuts to those budgets that have happened since. There's also a backdrop of a sort of cycle of commissioning, and so quite a disrupted and reducing number of resources really for community treatment. And this all then, a third layer of problems becomes the rising issue of alcohol-related admissions at hospital. These are deemed to have doubled since 2003, and we know that alcohol costs the NHS in England £3.5 billion a year, but the wider societal costs are more like 21 billion. And these figures are actually fairly out of date, so can suspect that the costs are higher than those stipulated. This is just a visual representation of those increasing alcohol admissions, both for wholly and partly attributable alcohol admissions. So that's within that context that we're looking at a larger proportion of attendances by a small proportion of people. So I'll take you through what that means at the moment. So who are people who attend hospital frequently for alcohol-related reasons? We know that they are a very heterogeneous group with multiple complex unmet needs. These cover physical and mental health problems, social care needs, and just wider general sort of practical support needs, all of which contribute to their circumstances. We know that they do not attend or access community addiction services. And for that reason, obviously, their route into care usually is through the hospital. And we know that the care that they receive through that route, therefore, is usually sort of more short-term, but high cost, and therefore lacking the longer-term support that they really require for their complex needs. And thus they have poor outcomes, and really you can see how that revolving door kind of scenario develops. They do feel very stigmatized. That can be threefold in society, as well as, unfortunately, in some healthcare settings. And indeed, the self-stigmatization aspect can usually be quite a preventer of even seeking appropriate healthcare in the first place. I've just got a note here on the nomenclature as well, because in previous literature, the population we're talking about has been referred to as alcohol-related frequent hospital attenders, or ARFA for short. So if you're delving into the literature, you may see that, but we now have the longer name, which is at the top of this slide, and following the norms of putting the person first, which is more respectful and appropriate. There's also a US literature on more broadly looking at frequent attenders and people who are termed high need, high cost patients. So it's another sort of term to look out for if you're scanning the literature. Some local work that we did in South London found that 9% of people with alcohol dependence accounted for 59% of the alcohol admissions, and that equated to 1.4 million bed days and £848 million, so quite a substantial proportion, again, by quite a small number of people. I'll probably, for the sake of time, skip over this slide, but I think as a quick glance, it gives you an impression of the multiple complex needs that come with this population. They can either be caused by their alcohol use or pre-exist that and be exacerbated. Some of these conditions may transpire in heightened alcohol use. So just to give you an impression of that. And also just a quick note on where this treatment model comes from. We all, well, a lot of us in the field know about the Stein and Test famous paper from 1980, where they really sort of developed what was case management at the time during a period that the mental health treatment system was being deinstitutionalized. And they became concerned with taking more proactive care based around the patient's needs to the patient in the community. And they called that assertive community treatment, or ACT for short. And in the UK, the version of this that also was in the, sorry, I should have said they're both in the severe mental illness population. So intensive case management, or ICM, was tested a few years later in the UK with the severe mental health population. The difference being that Stein and Test found really positive results, as did many studies in the US since then, and they found vastly reduced hospitalisation, among other positive outcomes. However, in the UK, with the same population, it was less encouraging, and this was very much deemed at the time to be partly to do with the fact that the mental health care system here was more advanced, and therefore the comparison was less of a big difference, shall we say. So since then, we've looked, there's 3 studies listed at the bottom of this slide where people in the UK have tried this service with populations with alcohol dependence. And these references will all be on my last slide for you to note. Just a quick description of the intervention itself. Some of the core components are listed at the top. So working with smaller caseloads, working in a multidisciplinary team, frequent contact, maybe weekly, maybe not, but frequent nonetheless. Majority of contacts taking place in the community. Sometimes that's at the patient's home. Holistic care focused around social and healthcare needs, and also physical and mental health and other practical requirements. And for an extended period of time, usually at the moment we're talking about roughly 12 months, but again, that can vary. And in red here, these are just aspects that we've introduced with our own intervention that tie it in quite well with that Stein and Test original model. So really focusing on assertive engagement with patients and assertive ongoing engagement as well, initially and ongoing. Allowing professionals to work across boundaries, ensuring that it's a patient-led agenda, working with networks in the community, true advocacy by key workers on behalf of their clients, and supporting patients to attend addiction services if that is indeed what they feel they would like to do, or other healthcare services. We also had a really super bank of volunteers who helped a lot with the care navigation aspect of things. I have a note here just at the bottom. We carried out a survey a few years ago of hospitals that said that they were providing alcohol assertive outreach treatment, and we compared them with those top 6 key components, and really discovered that an awful lot of places saying that they were delivering these services were not compliant with the core requirements of the intervention. So only 6 services were really sort of highly compliant with assertive outreach, so of note. And I think, you know, examples like a single key worker working with a very high caseload, and therefore probably prohibited from doing quite a lot of the other intensive work that's part of the care model. This is the paper that we published, which contains much more detail about our trials, so I'd refer you to that. I'll cover it very quickly at the moment, but it's all out in the public domain if you're looking for details. So in South London, we carried out a clinical trial, again using the assertive outreach treatment model for people with addiction to alcohol. The standard care that we were comparing it with was people who would be in hospital, would receive a simple referral to community treatment, but then no proactive follow-up thereafter, which is standard care in these settings quite often. So we identified patients through hospital e-records, and that was a variety of different attendance qualifications, mixture of A&E and admission numbers in 1 year or in a shorter period of time, but always with at least one diagnosis of alcohol dependence in the records. We had a multidisciplinary team led by consultant psychiatrists, but with nurses, key workers, volunteers, and at times other professions, allied health professions as well. And partnership working was very much a core of what they did as well across the environment. So we had 174 patients in the trial, 87 in each arm. And just to note that the team was funded by Guy's and St Thomas's charity, and the research was undertaken by the then South London NIHR Clark. I'm aware that's an acronym. I'm sorry. We're going to scoot ahead though. I don't have time to spell out the Clark. We'll go back over it if that's helpful. But basically it's a network of researchers and clinicians across South London and funded for by the NIHR. So we're on to the main findings. This is not my work. This is the trial statistician who produced this graph and did this work. That if I refer you to the green boxes on the right, those are the 12-month follow-ups for each arm of the trial. On the left, it's the control arm, and on the right, it's the intervention arm. And we measured percent days abstinent, which is the gold standard measurement for studies with people with alcohol dependence and other alcohol use disorders. So you can see that essentially we have a slightly higher percent days abstinent in the intervention arm, which was a positive outcome, but unfortunately in trial standards, it was not statistically significant. However, we moved in the right direction, and therefore that's qualification enough to carry out a cost effectiveness study, which was where I undertook a bit of work. And this is the very synopsis outcome of the cost effectiveness study. So I'll just do a quick description and skip ahead, but if you can see on the x-axis, there are QALYs, which are the standard quality of life measure for economic evaluations. And on the x-axis, we've got costs. And as most of the plotted scatters are in that southeast quadrant, it's showing that we've got an improved outcome and reduced costs, and the intervention is therefore cost effective. We then replicated that with the key trial clinical outcome, percent days abstinent, and happy to say that was the very much outcome again. And we did various other sensitivity analyses that held true. This is a cost effectiveness acceptability curve, which just basically shows that cost effectiveness has a good probability of holding across different varieties of willingness to pay as stipulated by NICE. And that's an above 90% consistency of cost effectiveness, which is a very solid outcome. I just wanted to break that down a little bit because I think it's very useful to understand where those savings are coming from and how maybe the service resource use has changed among the population. So what we do now understand better is that there's a very, very high use of inpatient care in both the trial arms for both before and after being in the trial. So baseline and follow-ups are high general inpatient service use. And they're also spread across a wide variety of hospital specialties, thus confirming a lot of the known multimorbidity within the population. But after 12 months in the trial, the people who had received the intervention did have lower inpatient resource use than those in standard care. Indeed, that pattern was continued through lots of the other aspects of resource use that we measured, whether it was A&E attendance, ambulance use, community services and criminal justice. However, the biggest difference was observed within inpatient care, and of course the largest costs are also attached to that. So Interestingly enough, I think we found that this was of interest, that there wasn't an increase in use of addiction services. Very much seemed that patients got what they needed from their key worker in that respect, and our key workers were all qualified in alcohol counselling. So that was, for me, certainly a very interesting finding. This is just a quick visual we did with the neighbouring King's College Hospital that shows what happened after we introduced the service. You can see there quite a sudden drop in their alcohol-related admission figures. And I'll just do a couple of minutes before I finish. This was a qualitative study that I carried out with participants of the AAOT trial. And I had 29 participants to speak to in the end, which was super. They talked about, before entering the trial, a lot about their circumstances and confirmed basically a lot of high and unmet need, as we've covered already. They also talked about their multimorbidity and confirmed that many had mental and physical health conditions, some one or the other. And again, very few had accessed alcohol community treatment services ever. So, I mean, interesting that this population really are not accessing care in any way, shape or form. Until, of course, they present at hospital with probably more severe and complex needs than would have been the case. So those receiving AOT had reported big changes in the way that they engaged with health services, and very few of the people who were in the treatment arm were able to report any changes in that respect at all. So we got quite a lot of feedback, and I'm going to do a single slide cover of that at the moment. But I mean, again, I'm happy to talk about this at another time in greater detail. 18 of the participants I spoke to were in the treatment arm of the trial, and their reflections on what they felt had worked well for them fell into two broad categories. One was the interpersonal aspects of the model, and the other was practical care that they received. So just to expand on that for a moment, the interpersonal aspects included the therapeutic style. They really felt that they were met where they were and sort of gradually and gently taken along, but they were very appreciative of the persistence as well, because so many of them had not engaged in care for such a long time. They really valued their relationship with their key worker and spoke quite extensively about key worker qualities that made this possible. And I think all that sort of points towards the real need to make sure the right people are undertaking these roles to make a real difference. And the practical aspects of support that were valued were very much the flexible format of engagement and support. So that's in terms of frequency, duration, location, as mentioned before. They valued the broad focus on all their needs. They valued the fact that they were getting practical care, help and support and advocacy with a lot of things that they were struggling with, as well as health, as well as alcohol problems. And they also valued the care coordination that they received. There were a couple of negative experiences, and I've put them in for good measure. A couple of people thought it ended too suddenly, and that in fact there was maybe bad timing in that respect, and there was one bad match between a key worker and patient, which we were aware of, and therefore these, I have to emphasize, these were tiny figures compared to the top two brackets of information. So in summary, just to conclude, AOT is cost effective. We now know that it's driven by small improvements in outcomes, but also combined with a biggish or a larger reduction in inpatient service use and cost. And we think that the motivators for this were patients really feeling supported with their variety of needs, feeling adequately supported with also their alcohol problems, feeling respected, listened to, perhaps not having fear anymore of stigma. They were better informed about their own health and their own drinking, and engaging with services. And they also greatly valued the therapeutic relationship with their key worker. So I do apologise that it was so fast, but these are the references which you'll get from my slides. And my thanks to my supervisors, the trial participants, and the AOT clinical team. And that's my email and would encourage you to get in touch if you have any questions. Or I think we're about to start publishing some of this work. So if you're interested in being alerted to when that's available, I'd happily keep your details. Drop me a line. Thank you.
Thanks very much, Amy, for a great overview of the work, and great to see it, see the final analysis. Also, thanks for sticking to time exactly. So we now are still on track, and I think we should move swiftly to the next one, which is me. Thanks very much. So I just wanted to introduce you to the program that we're going to be talking about for the rest of the afternoon, which is the Mental Health Implementation Network. And this arose 3 years ago out of an initiative by NIHR to commission national priority areas for collaborative research across England. And you can see there that there was 7 of those networks were commissioned, including mental health, which included children and young people's mental health. And we heard about the young people's research last week. Just to tell people, the applied research collaborations are NIHR-funded regional collaborations between universities, health and social care providers. And you can see that there's 15 in England. And what I've done here, the ones that are circled in red and green are the ones that took part in this project on assertive outreach. Sorry, the green ones are the assertive outreach, and the red are involved in other projects. So it was commissioned by National Institute for Health and Care Research and jointly led by the South London ARC and the East of England ARC. The aim of the whole thing is really to try and address the care gap in mental health. Can you go back? Sorry. Thanks. To address the care gap in mental health and the slow translation from research into practice. Also noting that there's uneven implementation across the country and that there are quite a number of underserved populations and conditions. Thanks. Next slide. So the aim of the Mental Health Implementation Network was to catalyse and evaluate implementation of high impact evidence-based interventions, either super-regionally or nationally, within a 3-year period. And this is us now just coming to the end of that 3-year period. So we convened a multidisciplinary group of key stakeholders across England, including people from Department of Health, NHS England, from professional groups, from different ARCs across the country. And importantly, also service users were quite heavily involved in developing this work. First of all, we wanted to prioritise service areas that required improvement and identify evidence-based solutions that could be implemented in practice. And I'll show you what they are in a moment. We also worked quite a bit on deciding on implementation approaches or methods that were realistic to do in typical NHS or third sector practice, and to evaluate that implementation activity, to look at the impact of it, and you'll hear about that after I've finished. So we also conducted an evaluation of the programme as a whole, and we have a presentation on that later this afternoon. So next slide, please. So the work was really in 3 phases. We started with a prioritisation exercise that I'll explain shortly. We then recruited a number of ARC regions around the country to participate in this project. And then we went through to implementation and evaluation, which has happened over the last year or so. Next slide, please. So these were the initial long list of priority topics for implementation that came out of a number of sources. So we did a literature review, a scoping of areas of mental health that were under-researched or under-implemented. We also did a national stakeholder survey across mental health, and had many responses coming back to that. And through this process, we identified these areas. But of course, we couldn't take forward every single one of these topics, so we had a further prioritization process, which I think is the next slide. If you move to the next one. So we put together a number of criteria to prioritize the interventions. So they were addressing a local need, that there was an appetite to adopt them within local care systems, that they had evidence of delivering improved outcomes. So it wasn't enough just to have a positive trial. We wanted to see that it had actually been implemented beyond a clinical trial, and that it had been commissioned in the real world of the NHS. So sometimes, as Amy was saying, a lot of the research evidence here is actually not from the UK, and there's question marks about how applicable some of that work would be to the NHS. We wanted to make sure that patients had been involved in the intervention design and development, and that providers and commissioners were receptive to implementation. Okay, so there are a number of criteria. Next slide, please. So we went from the systematic scoping review survey, and then an expert opinion survey, and finally we had a decision-making workshop with a number of key stakeholders, including service users, to decide on the final 3 that we were able to take forward. So these are listed on the right of this. The first one being improving access to mental health services for minoritized ethnic communities. And if you're interested in that, their dissemination event is actually taking place next week. The second one was children and young people's mental health, and that dissemination event took place last week, but it will be available as a downloadable podcast. And the final one, integrated care protocols for substance use, mental health, and physical health. And that's today's topic. Okay, next one. So you can see that the third project on assertive outreach, so assertive outreach was prioritized as an intervention that had been implemented beyond clinical trials, as Amy's survey showed. The survey was actually carried out by Stephanie Fincham Campbell, but quoted there by Amy. The chosen implementing ARCs were Yorkshire and Humber and Greater Manchester. Okay, so that is just by way of introduction to the Mental Health Implementation Network. And we're now going to hear from our 2 implementation sites. So I think first up is Dr. Stephen Carr, who is a senior lecturer and consultant psychiatrist in Manchester. And he's going to talk about the Manchester experience of implementation.
Thanks very much, Colin. Let me just check my screen. Here we go. Okay, so yeah, thank you very much. So my name is Dr. Stephen Carr. I'm a consultant addiction psychiatrist at the Chapman Barker unit, which is an inpatient detoxification unit in Prestwich in Manchester. It's part of Greater Manchester Mental Health Foundation Trust and an honorary senior lecturer at Manchester University. I'm here today because I was the lead on the Alcohol Assertive Outreach Treatment Evaluation in Greater Manchester, that's AAOT, and we called our study VALOR, which is the value of outreach. So today I'm going to talk about the services that we've studied as part of this evaluation. I'm going to talk through our quantitative service evaluation, which looked at routinely collected clinical information, and then our qualitative study, which was a prospective study, and then think about next steps. And a lot of the themes that I'm going to talk about today will be will mirror some of the topics that Amy talked about and Tom is going to talk about after me in Hull. So really, with the Valor project, we wanted to look at several aims. As Amy alluded to, there is a model for alcohol assertive outreach treatment and alcohol assertive outreach teams. And we wanted to see whether the teams that we were studying had fidelity to that model, and also what we could learn from maybe differences in those teams as well. We have some service user informed outcome measures, and we'll reflect on some of the outcomes that our service users have talked about at the end of this study, because that came up in the qualitative element. We wanted to look at the role of comorbid mental health conditions, and that's something that we still need to examine further, really, because at the moment we haven't managed to pin that down in our data set, but we'll keep working on it. Eventually, we'll be looking at the health economic impact too, although I think there's some signals of some really important changes in health utilization, which again echo what Amy's talked about and again what Tom will talk about. I think what was really critical for us in GM was looking at the sustainability of the alcohol assertive outreach teams. And luckily, that is something that's part of the framework analysis that we conducted. And then also we wanted to do these kind of events where we disseminate our best practice around implementation, and also how these services are designed, developed and sustained. So within Greater Manchester, we have something called the Achieve Partnership. And this is a cluster commissioning arrangement that's led by Greater Manchester Mental Health Foundation Trust, who have the commissioning arrangement with the local authorities in Bolton, Salford, Trafford and Bury. So under the Achieve umbrella, GMMH deliver alcohol assertive outreach services in both Bolton and Salford, which were the two sites that we picked for this study. So GMMH subcontract to other organisations, including the Big Life Group, who are a third sector organisation, an organisation for social change. And they work across Bolton, Salford, Trafford, Bolton, Salford and Trafford, where they provide alcohol assertive outreach team services. And so we looked at their care that they delivered in Bolton. And in Salford, GMMH with the Northern Care Alliance run a team called the High Impact Substance Misuse Team, or the HISMIT team, who are another alcohol assertive outreach team who have actually been running for nearly 20 years now, which is why, again, sort of sustainability and reinvigorating these teams was really important as part of the study. I think the other thing to mention is that one of the advantages about this organisation being led by an NHS trust is that we all had this, all these organisations use the same electronic note system, which actually made it much easier for us to collect this retrospective data and evaluate these services. So here are our two teams, the Big Life team on our left here and HISMIT team 2. And you can tell actually that the two teams are quite different in terms of their sizes and resources, and that's something that we'll reflect on in a minute as well. So because fidelity to the model and the model of alcohol assertive outreach is quite important, I just wanted to think about how our two teams adhere to the model, and because this will come up, I think, in our analysis. So the HISMIT team is potentially a more traditional alcohol assertive outreach team. This is the High Impact Substance Misuse team in Salford. They work primarily with alcohol patients, but they recently expanded to look at to treat people with substance use as well. They specifically work with people who have at least 2 referrals via A&E in a month. Then they, if that's related, if those referrals or those admissions or presentations to A&E are alcohol related or drug related, they hit the threshold for being referred to the team. So they automatically select people who are attending A&E at a high frequency, because this is one population that we know this model of care should be able to help with. And they tend to work with people in a case management fashion for up to 12 months. And their goal is to reduce unnecessary hospital admissions. And they tend to have a slightly lower, smaller caseload. Big Life, on the other hand, have a slightly different remit. So they accept referrals from all different organisations for people who have struggled to engage in structured care. And when I say structured care, I mean traditional drug and alcohol services. So Big Life is specifically tasked with getting people into structured care so that they can receive treatment for their alcohol use disorder or alcohol dependence. They therefore tend to work with people for a slightly shorter period of time. And this will be borne out when we start thinking about our analysis. But if you were to look at a patient's journey throughout the big life involvement, they tend to engage with people multiple times over that period.
Sorry, Stephen, could I just
Yeah.
say, do you mind changing the display setting at the top to keep
Yeah.
presenter mode? And I think people are struggling to see the.
Is that better?
Yeah, perfect. Thank you.
No worries. All right. So I think that's all I had to say on that. And the caseloads are slightly higher in big life. Thanks for telling me, Colin. But I think that the key thing to take home from both teams is that they really have this assertive attitude, which is where patients are treated at home and workers have this flexible, pragmatic approach to engaging and treating people. So as I said, we did a mixed method study design, which had our quantitative service evaluation. So that was the retrospective analysis. And we collected data from the electronic patient system in GMMH, which included all the addictions and mental health clinical data. We then organized DPIAs, so these data sharing agreements with our general hospitals in Bolton and in Salford as well. The other part of our study involved using semi-structured interviews and framework analysis prospectively with staff, service users, and key influencers involved in alcohol assertive outreach treatment. So I've kind of alluded to some of the aims of the study overall. In terms of what we were looking at when we did our retrospective service evaluation, we wanted to describe this population both in terms of their clinical characteristics and their demographic characteristics. And that's something that I'll be able to talk a little bit about today. We also wanted to see how they engaged with the alcohol assertive outreach teams, and also whether there was a change in acute hospital, mental health, and substance, so structured care, service utilisation, both before and after involvement with the alcohol assertive outreach team. We also have some secondary aims, which include a between service comparison, so between Big Life and HISMIT, but also potentially looking at how our services here in Manchester differ to services in Hull and what we might be able to say about that too. So we were able to get anonymized aggregated clinical data from 12 months before and 12 months after. And this was over a 4-year period, roughly. And again, the NHS Business Intelligence Department were really, really helpful in helping us to get this data and to keep it anonymized. So if we look at the total number of referrals to our alcohol assertive outreach teams in these two sites, there were 6,512 roughly over the same period. We're going to talk today about these presentations here. So our Big Life Bolton referrals, who were then narrowed down to alcohol misuse referrals, who we then narrowed down to our first episode referrals. So all the information I'm going to present today is talking about a patient's before and after their first referral to Big Life. And you can see we still ended up with quite a nice sample size there of 1,043 people. You can see that when we looked at HISMIT, which is the slightly different team in Salford, there were far fewer people, but then they worked with them in a continuous manner for longer. But today we're going to be talking about our Bolton Big Life population. So in terms of age and gender, you can see that there's far more males than females, 61% and nearly 40%, which is quite common to our other alcohol services in Manchester. In terms of age, we're talking about people in their late 40s. Just looking at some of the other demographics, we can see that lots of people, when asked on the NDTMS, noted that they had multiple disabilities. Most people were in mainstream housing, but there were some homeless people as well. In terms of sexual orientation, the vast majority of people were heterosexual, although some other LGBTQ people were involved as well. And in terms of ethnicity, they tended to be the vast majority of white British, which again is quite typical for the treatment accessing population in Manchester, but is clearly not representative of our general population. So we need to do much better at making sure that marginalised groups are included in these kinds of services, which I know is something that Big Life really seek to do. In terms of our mean length of treatment, so this is where perhaps the fidelity to the original AAOT model might look a bit different with Big Life. And you can see here that the mean duration of treatment length, that's the first treatment length, is 61 days, although there's a big range. But what I would say is that this is just the first treatment episode, and often people will have multiple treatment episodes over a long period of time. So Big Life are having that long-term relationship with people, but the treatment episodes are a bit shorter. And that's something that we just need to figure out how to bring out in our analysis. If we look at the key aim of Big Life, which is to increase contacts with structured addictions care, you can see here, though, that actually our purple line is contacts with structured addictions care, so traditional drug and alcohol treatment services before involvement with Big Life, and you can see the blue line is involvement after. So actually, in their core goal, Big Life really are increasing how this group of people who usually typically struggle to access structured care are now accessing structured care. So that's great. What we also wanted to do was look at some of those other measures, though, that Amy talked about and which Tom will talk about too, when it comes to seeing whether Big Life changed the unplanned medical usage. And you can see here that overall this population were accessing A&E roughly 3 times in 12 months, and there was a significant drop to more like twice, which is, reassuring. But what about if you look at the people who are high frequent attenders? So in the people that attended A&E more than 5 times in a year, of which there were 112 in that population, so about 11%, you can see that they dropped from 12 average presentations to A&E in a year down to 9, which again was a significant drop and likely is a considerable cost saving, although we've not got to the point of doing an economic analysis at this stage. If you look at hospital bed nights, so this is unplanned hospital bed night usage in a general hospital, so in this case Bolton Royal Hospital, you can see that the total group were presenting roughly 4 to 5 bed nights in a year, and that dropped down to 4, again a significant reduction. But if you looked at those population of people who are attending A&E more than 5 times in a year, if you looked at their change in bed night, you can see that it dropped a bit more. So again, Big Life does seem to be having an impact on people who are high frequency attenders to A&E, both in terms of their A&E attendances and also their bed night usage. And again, just another metric, so this is ward admissions before and after Big Life's intervention. You can see on average people are having at least 1 ward admission a year to the medical wards, and that dropped significantly. But if you looked at people who were having lots of medical ward admissions in a year, in this case more than 3 ward admissions in a year, you can see that the average in that group of people dropped from 5 unplanned medical ward admissions a year down to 2.5. So again, this is early preliminary data, but there are signals there that actually these services are effective. So now I just wanted to finish off by talking about our qualitative study. So Laura and Nikos, who I work with, have done a fantastic job at recruiting and interviewing 58 participants. So we've got 18 service users, 20 members of staff, and 20 stakeholders. And we've used a kind of combined framework approach using the CIFR, which is the Consolidated Framework Implementation Research, and Proctor's taxonomy as well, which focuses more on outcomes from the implementation. And for anyone who's interested in applying this kind of implementation science to their own services to look at implementation, these are some of the domains within Proctor's taxonomy. And we've kind of looked at all of them to an extent, but I think sustainability is one of the key things that we were interested in GM. And as you can see, we've also talked quite a lot about fidelity too. So again, these are preliminary results from roughly half of the interviews that have been transcribed now. And you can see, if we look at our service user group, the themes that came out were culture, outcomes, and the outcomes that are important to service users, and fidelity. In terms of staff, they were talking about the characteristics of staff, partnership working, funding and sustainability. And our stakeholders, so those higher level people who are involved in policy, commissioning, setting up AAOT services and other relevant services, spoke more about reflecting and evaluating and sustainability, funding, and culture. And so now I'm just going to quickly go through some of those quotes. So in terms of culture, this is from the service users. Recipient-centeredness is a construct from the CIFA, but they described how services were hope-inspiring, trusted. They found they had motivational relationships with their AAOT workers who went above and beyond the expected duties, that they found people informal and non-judgmental. And there's a quote here too. This is from a service user. So as soon as you are not on their list of young people or young adults, they're normally just, that's it. But having someone that you can ring, even though you're not on their list, makes you feel a bit like, well, you know, I must mean something. I must be worthy of this help. And so then outcomes was another theme, which included being engaged with support and treatment, giving hope for the future, improved relationships with family and friends, improved mood as well. And the quote here is, the way I feel at the minute, like I say, I feel more balanced. I feel more in control of things. It's just like she just opened a lot of doors for me, a lot of different doors. And then fidelity. So this is another, I think, positive theme that's coming out of our research, which shows that people really, service users really value this model and the assertive approach from staff, including these frequent contacts, reminders of appointments, going above and beyond, and this place-based care, so home visits. And the quote here is, she made sure I went to my appointment. She come and picked me up and drove me there, and that's extra, if you know what I mean. Going the extra mile, so I like that. And how about staff? So staff spoke about the key characteristics that staff need in order to deliver alcohol assertive outreach treatment. And they spoke about staff with knowledge, skills, being passionate about the role, having the opportunity to work flexibly with service users. And the quote here is, I'd like people to be able to talk with a smile, be able to think on the fly, be able to do dynamic risk assessments, not just think, this is what I've got to go and work with, and not have their eyes open when they knock someone's door, and be able to use their own initiative. So being creative and using initiative, being pragmatic. They also talked about how important partnership and multi-agency working was in order to help the people that these services identified. And here's the quote again. If we closely link with the alcohol care teams at the hospitals, provide the clinics that we do, support those individuals and create a good network resource, multidisciplinary team with the hospital and the treatment provider and ourselves, with the treatment provider and ourselves, then the number of referrals that we're receiving is substantially higher. So there's something about the success of these services, but also the demand on these services, which needs to be managed as well. And of course, funding and sustainability came up. So one thing that was mentioned is that these AAOT teams tend to be small teams, they tend to be limited resources, and also there's something about the way these services are commissioned and the way staff are offered short-term contracts, which often make it challenging to sustain, recruit and retain people. And here's the quote. Trying to recruit new people was really, really difficult. And like you said, a lot of it is because it's just a short-term fixed contract that people shy away from, and there's just not the right number of people or the right quality of people applying for certain posts. And I think you could probably transfer that to any NHS organisation at the moment. And finally, stakeholders. So stakeholders reflected on and evaluated sustainability. So they felt that research and evaluation in demonstrating the impact of AAOT was key to this sustainability, and that's what we're doing today. The example being, funding is going to be the main thing that you deal with. That is, you make sure that you're collecting the data that shows that your service model is working and that you've reached the right people and that you know it's actually having an impact, and therefore you can build a case to continue the funding, which is hopefully what we're doing today. And when it comes to funding, the stakeholders identified this as a key challenge to the sustainability of the model. For example, the big problem they have is funding. That's how does it fund, who funds, and really what you have is a mental health and addiction stream funding something that creates savings in the acute stream, because it's not really properly funded, is my understanding. And that's really, you know, it's making the case to the acute sector, you're benefiting from this and you should fund it. And if some of the signals that we've seen in our quantitative analysis are borne out, then I think we can really sell the fact that these types of teams do reduce the burden on hospitals. And finally, culture. So again, deliver a centeredness for a construct from CIFA, but having a learning-based culture is key to sustainability and development. So this is sort of that staff within the service feel they can learn, adapt, be creative and flexible and grow really is key to running these teams. For example, I think you need a culture that kind of encourages staff to be inspiring with each other. You need a culture that allows staff to think outside the box, still working safely, but to not be too structured with everything, to not dictate terms of, we work with people, as for example, we work with people for an X amount of time and that's it. All right, so I hope that's been useful in illustrating some of our preliminary data analysis, both quantitative and also those qualitative quotes there as well. In terms of our future aims, we obviously need to finalise our analysis, and we'll be doing that over the next month or so. And we also intend on expanding this into other alcohol assertive outreach teams in Greater Manchester, and potentially working with the central MHIN team and our ARC team as well in Manchester to work with our local ARCs in Liverpool and Cheshire too, to continue this evaluation. We've got our own event that we'll be running on the 21st of March. And I think something else that's really positive that's come out of this work, something that I wasn't particularly aware of before, is the communities of practice. And I know Afra, Julie and Denise will be talking about how useful that's been in helping Hull set up their service, but also helping us sustain our services as well. We are, as I've mentioned several times, quite keen to ensure that there is sufficient funding to look at the sustainability of these teams, because we're aware local authorities have tight budgets and difficult priorities to meet. We'll also continue working with our central MHIN team in KCL. We're going to provide some infrastructure support for the communities of practice, and we also look forward to collaborating with Hull as well. And finally, I just want to acknowledge the rest of the team, because it's been a huge team effort. So Nicholas, Laura and Ansha have been critical to the data collection and data analysis that I've presented today, so thank you for that. I also want to really thank Colin and all the rest of the mental health implementation Project 3 team, Karina and Tracy, Julie and Denise, who you're going to hear from later, and Stephen, our PPI lead, who'll be talking later as well. And then all the other members of the group that helped with the data analysis. Thanks so much. That's it.
Great. Thank you, Stephen. Some really interesting results there. And, I think very much kind of echoing what the clinical trial showed, although obviously this is different from the clinical trial. You don't have a randomized control group, but good to see it's borne out in practice.
Thanks.
And thanks for sticking to time. So I'd like to now introduce Tom Phillips, who is a professor of addictions and nursing in Hull University. And Tom's been leading the work in Humberside. So over to you, Tom.
Great. Just going to share my screen, and I just want to check with you, Colin, that you can see the slides.
Yeah, that's super.
That's
Thanks.
great. Thank you. And thank you again for inviting us to share our experience in Hull this afternoon. And some of the overlap with Stephen I'll point out. But first of all, I just wanted to thank our team at the outset, which is Dr. Philippa Case, Research Fellow with us at University of Hull, Laura Herman, who's worked sternly hard to collect data and do interviews as a research assistant, and Professor Judith Cohen, who's director of our trials unit. And that's just a small part of our evaluation team, which is made up of representations from our clinical service, which I'll talk about in a bit more, and our ARC structures that support this project. In terms of hopefully understanding a bit more about our area, Hull City sits on the east coast, as many of you will be aware, is an old fishing trawler town and has high levels of deprivation. It has very high levels of alcohol dependence, almost twice that of England. And it's been observed that there is increasing alcohol mortality over the last few years. Fundamentally, and we're working very closely with Hull University Teaching Hospital NHS Trust, is to sort of identify people in the hospital setting through the alcohol care team, because of the rising number of alcohol-related admissions that you've already heard about. So in terms of our implementation, we're slightly different to Stephen in that we've gone from scratch in 2 years in setting up a new alcohol assertive outreach team in Hull. We were fortunate enough to have an ongoing relationship with the City Council and many other public health leads across our patch. And we had already established that alcohol assertive outreach team was a priority for our area in around 2021. The MHIN project came along and provided some momentum to actually consider early adoption of this model with the evaluation and working together with our colleagues in the addiction services on the patch. Our addiction services across our area are led by Renew, CGL led in Hull, and we've worked very closely with their leadership team, Diane Hilton, Luke Ingemels and Magic, who have clinically led and been involved in the development of the service. But fundamentally, we could not have done what we've achieved in the last 18 months without the workforce and the practitioners who have been so impressive in delivering this service. And today I'm going to share some outcomes, obviously, on those the data for the patients. In terms of our inclusion criteria, we came into operation in July 2023, having commissioned the service in November the previous year. And we looked at a criteria built around the model that was being proposed by Amy earlier around high quality assertive outreach teams, supporting those in much greater need and complexity. So we work closely in developing care pathways between the assertive team and the alcohol care team in the hospital. And we identified that initially we'd target to try and recruit 60 service users in the first year. And we've achieved 40, and I'm going to present some data related to that. And clearly this has created a huge amount of body of work around supporting staff to develop and partnership working across the patch. So a big thanks to a number of the organisations that are listed here, particularly obviously Renew as our clinical lead, and you'll hear from Luke Ingemels and contribution from our PPI rep, Ruth, later around the background to the project. But also to the Mental Health Trust on our patch, and of course the Acute Trust and the other partners, including MHIN. So we called our project COACH, and that stands for Collaborative Alcohol Care in Hull. And our evaluation is a multi-method evaluation of Hull Alcohol Assertive Outreach Service. And we formulated a project built on 2 areas. First of all, a clinical audit, which would examine the characteristics of service users and assess the impact, primarily looking at hospital admissions and A&E attendances, given the relationship with the alcohol care team. We also have conducted a qualitative evaluation to explore acceptability and feasibility and the impact of implementing alcohol assertive outreach team from scratch, and looking to what extent we are aligned the fidelity to the high quality model presented by King's and others previously. So in terms of the clinical audit, which will be the focus of the presentation today, we've been looking at routinely collected data from services, both at Hull Royal Infirmary, in looking at hospital service use over previous periods of time, and we collected that data at referral, and we also recollected that data at follow-up periods, which I'll describe in a minute. But we also wanted to characterize the service users who are engaging with our assertive outreach team and to look at their levels of complexity of need. So we were looking at demographics, living circumstances, social support that they were receiving, and the presence and severity of different problems, notably alcohol and common mental health disorders. And the idea was that we would look at the treatment outcome profile, which is a mandatory sort of tool that's used in specialist addiction services to monitor outcomes every 3 months, but also look at outcomes for hospital use at 3, 6, and 12 months. And we're going to report our 3-month data today. In addition, the qualitative element would look at various qualitative aspects, service user interviews between 10 and 12, staff focus group, including a number of staff obviously delivering assertive care, and stakeholder interviews. We have completed our service user interviews just this week, and our focus group with staff also has been completed. Our analysis is not yet refined to the point that Stephen and the colleagues have, so we'll be reporting those at a future event. But we have used a framework approach, and we've used Proctor's framework for implementation studies, looking at acceptability and adoption and appropriateness of the service costs, and again, fidelity. And thank you for Stephen for introducing that paper to us, but that will allow us to make comparisons between our studies, which I think will be useful. Just to say a little bit more around the clinical service. CGL are obviously a national provider across the country. They've been in Hull for a number of years as the lead provider for addiction services. But developing and supporting the implementation of assertive outreach services was brand new to them as a provider. And having been commissioned to provide the service for a minimum of 2 years, which started in 2022, there was a steep learning curve for all of us to support CGL and the colleagues to take up the baton for assertive care in our area. And this is key because it's to what extent can we implement a quite sophisticated model and a change in direction for services from a sort of relatively low base in terms of assertive care. So in the city, we have alcohol services and drug services, but there's an alcohol base towards the north of the city. But here was an opportunity to provide outreach across the whole of the city area. Under the leadership of the service manager, Luke, who you'll be introduced to later, and a clinical nurse specialist who's pictured to the right, Claire Rossi, with support from clinical psychologists. We identified 4 very keen practitioners who have got substantial experience in social care and addictions to actually be the leaders in terms of delivering the care in accordance to the sort of description provided by Amy earlier. So the initial task was to identify up to 60 individuals in the first year, incrementally introducing individuals to the service to allow for any glitches in terms of process, any issues in terms of clinical problems, etc. And currently the caseload is up to 40. And in terms of the evaluation team obviously had to work with the service to integrate measures into the service, gain access to the electronic care record operated by CGL through data sharing agreements and non-disclosure agreements, and then provide audit tools and support for record extraction. Laura has been embedded as a research assistant within the team over the last 6 months, and also she's reflected on some of her thoughts around the project. We haven't had time to obviously synthesize our qualitative interviews, but we have all kept a sort of reflective piece around the discussions that we've held in regular 2 weekly meetings that we've had with the team. And I'm going to present some preliminary data for you. So hopefully you can see this. To date, there's been over 50 individuals referred, largely from the alcohol care team in hospital, and 40 individuals were engaged in the actual service. A number declined the referral, and the significant complexity around palliative care and also lack of capacity meant that a number of individuals could not actually engage in the service model. And this sort of shines a light on refining the referral pathways for everybody and the sort of, I suppose, the developing the and refinement around the inclusion criteria. So currently there is 40 individuals at the time that we actually took the cut in the data to have a look at the data in terms of providing you with some follow-up data and outcomes. And there have been, sadly, a number of individuals who've passed away just over this short period of time, which I think reflects largely the physical comorbidities of individuals who are experiencing on referral. So the data available for us to look at and sort of present is 36 individuals who all have received alcohol care, assertive care, for a minimum of 3 months over this period. 12 individuals have reached 6-month follow-up, but we haven't focused on presenting that data today. So just to draw some comparisons with Amy and Colin and colleagues' trial around assertive care, we've looked at comparing descriptive data around the characteristics of our patient group with the AAOT trial arm, the 87 that Amy was discussing earlier. And we could see some similarities around gender and age, but there are differences around ethnicity and relationship, and that's perhaps more reflective of our regions. So Yorkshire and Humber has less diverse communities than perhaps South London. And also there's a different demographic in terms of marriage and relationships. But in terms of age and male engagement, excuse me, they're very similar. There's some slight differences around accommodation, with a smaller group being owner-occupied in both groups, higher proportion of renters, and we do have some missing data in the whole group, which is made up of 4 individuals who are actually identified as homeless. In terms of alcohol severity, again, we can see similarities. Percentage days abstinence, which is the period or the amount of days not consuming at baseline at recruitment, was similar in some respects to the data for our individuals in gaining access to assertive outreach. In the trial, it was 29% days abstinent, and in our study, it was 36 days, or 36% days. In terms of alcohol severity, individuals are very severely alcohol dependent, and APQ stands for Alcohol Problems Questionnaire, and there's a higher index of alcohol problems in the whole group. And we can see that the vast majority of individuals define themselves as heterosexual. We also conducted a inventory around identifying people's most important support structures. The Important People Inventory is a tool that can be used to help guide and support care and support in communities, and helps clinicians and practitioners work with significant individuals that are identified by patients as being important in their help and care. And in our study, we identified that each 60% of individuals identified a highly significant individual in form of a relative or friend or significant other who've been incredibly supportive and extremely helpful in sort of their initial help and assistance. This is important because it identifies the potential support structures that practitioners can work with in the community. That said, we also identify the drinking status of individuals, and we can see here in our data that 55% of the significant individuals who are supporting our patients are drinking. So that creates potentially some risks for individuals. And also they offer differing views and levels of support regarding people's levels of drinking, but they are all, almost all, very supportive of individuals entering treatment. and the support offered by assertive care. So in terms of our profile, we've offered some box plots here that help you interpret the severity. The blue box is around the audit score, and we can see on average people were scoring around 30 out of 40 on the audit, and the audit stands for the Alcohol Use Disorders Identification Test and is used as a clinical measure in many services nationally and internationally. And the severity of alcohol dependence questionnaire gives us an idea of the severity that people are experiencing. And this is linked to the severity of problems that people might experience. And we can see here over 50% of individuals in our sample of 36 experience very severe alcohol dependence. This would normally mean that they need very intensive support. So it suggests that they are the right cohort to be looked after by assertive care. But also we can see in the boxes here that we've measured baseline common mental health disorders using 2 routinely used questionnaires. So one measures depressive disorder symptoms, which is the PHQ-9, and the generalized anxiety disorder scale of 7 questions is in red. And we can see here that both these are elevated to the point that people are identified as experiencing moderately to severe levels of common mental health disorder. So this sort of helps us identify the potential complexity regarding mental health. And we've also looked at measures around health and functioning as reported by individuals. These are recorded on what we call the treatment outcome profile, and they are a measure of either poor or good health across 3 domains: psychological, physical, and overall health. And we can see that these are all geared towards the low end at baseline. But fundamentally, we wanted to focus this presentation on estimating hospital use and costs. And we've identified specific costs from previous studies that we've undertaken. And we've identified the mean average cost for A&E to be £167 and the mean average bed day cost for inpatient care to be £630. Across our overall sample, we can, of 36 individuals at baseline, we can see that on average, individuals varied different to the Bolton sample in that our individuals experienced up to, on average, 4 admissions each, up to 25 occupied bed days each, and 7 ED attendances, which, using our costing structure, identifies that each individual exerted potentially a cost on their hospital of around £17,000. And if we looked at the previous 12 months for that group, we can identify that the estimated cost of impact on hospital use was around £600,000 for these 36 individuals prior to engagement in assertive outreach team. We had built a business case around 100 patients, potentially having an estimated cost of 1.5 million, and these figures seem to be in line with our previous estimates. This slide is a bit busy, but I'll explain it to you. First of all, across the bottom of the axes, the horizontal line, we have quarters of the year. And in the blue box, we have hospital occupied bed days. In the orange box, we have ED attendances. And in the grey box, we have hospital admissions. And these identify the mean number of admissions or impacts on the hospital at each quarter. At the right-hand side, we have our baseline, we have our 3-month follow-up period, and the green line denotes that engagement in the assertive outreach team. And we can see that if you compare the 3 months follow-up period to the 3 months prior, there's significant reductions in hospital use, particularly in terms of bed days and admissions, and perhaps some around emergency care. But importantly, we can see that that trend is very much significant across all the previous quarters, suggesting that this has potential to identify considerable impacts. So when we look at this, we can actually look at there are significant differences in the drop of admissions at 3 months prior, which was 1.4, compared to a reduction of under 1. And occupied bed days are halved in those periods, and as well, almost ED attendances. But significantly, the estimated costs are reduced. And we can see that 3 of these domains were statistically significant. So what does this mean? So whilst it's important to be cautious about overinterpretation of just one data point, it is worth identifying that Amy and colleagues have identified services to be cost effective. And our data points that if we were to compare the previous 3 months with the post 3 month period, there's a potential saving in that quarter of over £100,000 in terms of hospital service use. And if we were to compare the follow-up period of 3 months with the sort of the mean quarterly cost, there's an existing service cost saving of around 66,000. So really positive sort of indications that this intervention saves money. So what else? Well, our reflections have shown in terms of feedback in discussions, significant levels of positive adoption of this model amongst patients. Health concerns are being tackled, and there's a real need for service user priorities to be tackled on a practical basis. We've identified that competing priorities mean that working with the patient on their priority areas is fundamentally important. For practitioners, I think there's a global impressiveness around our 4 practitioners. It's taken time to embed new ways of working, a new ethos, but they've clearly demonstrated a passionate and compassionate sort of approach and going well beyond the call of duty. And they've been supported both by the team locally, but also the communities of practice that Stephen mentioned. And that's allowed them to maintain a high level of support throughout this period. And finally, I just want to point out sort of reflections on the service. It's a brand new service model for CGL. It's been a steep learning curve, and there has been significant adaptations required over that time to lots of different components, including MDT working, referral pathways, and particularly clinical guidelines. So finally, what achievements do we think we've made? Well, University of Hull is a civic university, which means it has a responsibility for creating change in our local area. And our relationships with strategic planning and supporting research-informed commissioning has gone from strength to strength. And this is just one example. There's greater collaborations between all our partners, those locally, but also nationally with Manchester and the MHIN particularly, and the ARC. And the engagement of services and communities of practice has been incredibly impressive. So new opportunities for us are around clinical priorities and service areas. We've got ideas around developing Coach 2 with Philippa Case leading on a sort of a further project to build on this and building on our work in profiling addiction and mental health research in this area. And thank you. I'll leave you with the contact information in terms of an email.
Thank you very much, Tom. Really good to see those results. And it's likely whichever government we have over the next 12 months, they're going to be looking for ways to save money. And I think both Manchester and Hull presentations have produced important data that I think could inform some of that decision making. It's probably also worth saying at this stage that we have been granted an extra 12 months of funding from NIHR to continue with dissemination of this research and producing a number of outputs. Obviously, there will be research papers, but we're also planning to produce implementation guides, how-to guides, and so forth for people that would like to try and set up these services in their local area. Just a reminder to everybody who's still with us, we've got the Q&A function at the bottom of your screen, which you can put questions in for any of the presenters, which we'll pick up later on. Yeah, Tom.
Sorry, that was a little mistake. I was looking at the Q&A
right,
function.
okay.
Sorry, Colin.
All right, okay. You found it. Okay, so we will have a slot at the end of the afternoon to take any questions and have a discussion about the findings. Okay, so I'd now like to move on to the overall evaluation of the MHIN program, and we have Dr. Shalini Ahuja, who's a lecturer at King's College London, and Dr. Blossom Fernandez, who's a postdoctoral researcher at London School of Hygiene and Tropical Medicine, both of whom are implementation science experts, and they have been looking across the whole of the MHIN program at impact across the 3 projects, but I think you're going to focus a bit more on project 3 today. So over to you. Thank you.
Thanks, Colin. Just put our slides on. Thanks, Blossom. Good afternoon, everyone. For the next 10 minutes, we'll dive deep into the program-wide evaluation of mental health implementation network. Next slide. So Colin has already detailed what the purpose and function of MHIN is. And now you know that mental health implementation network involves multiple sites, 6 ARC sites, covering 3 priority mental health areas. We call them projects, and multiple provider organizations, including trusts, charities, and AHSNs. Our evaluation at program level aims to understand how all these components and systems work together. We also focused on offering evaluation support to the MHIN sites. Next slide. So our study is based on this conceptual model that considers the contextual factors on the left-hand side influencing implementation, as well as the strategies used and their impact on outcomes, both for services and for patients. So this framework that you can see draws from the work of Aaron and colleagues. It was published in 2020. It is really providing us with the foundation of our evaluation. So essentially, the figure illustrates how various factors influence the success of AAOT intervention. So we have the system context, like the support from commissioners, and the organizational context, such as readiness in the hospitals, and how all these factors, they contribute well to the intervention. For example, intervention fidelity, meaning how closely AAOT is delivered as it was intended. But here's the interesting part. In between the context and the outcomes, there's generally a black box. We have a blue box of implementation support. So this includes structured support, like the guidelines for health and social care professionals, but also unstructured support or additional support, like the collaborative strategies and efforts of research networks such as MHIN. Well, our hypothesis is that these collaborative strategies, both at MHIN network level and also within the ARCs, are crucial for successful implementation and scale up of AAOT. So over the next few slides, Blossom, my colleague, will explore the intricacies of our evaluation and how it is shedding some light on the value of networks such as MHIN. Over to you, Blossom.
Thanks, Shalini. So like Shalini mentioned, I'll be delving a bit deeper into the evaluation. Our evaluation was conducted working with our partner sites, and it focused mainly on the implementation support. This is the additional support delivered to the sites by MHIN. The structured implementation support was delivered by our sites. So the additional implementation support was done following the prioritization exercise, which led to engaging our PPI teams and all our other work streams. So support was provided by all work streams as needed. And just taking communities of practice, for example, this was led by our implementation team and supported by our PPI team. So this was established between the Greater Manchester side and the Hull side. The support that was delivered that was then categorized using ERIC. So the expert recommendations for implementing change tool. So this was based on a study conducted by researchers who got together to firstly refine compilation of implementation strategies and develop conceptually distinct categories of implementation strategies. So this led to a compilation of 73 discrete implementation strategies, which were then categorized into 9 thematic clusters. So these are the 9 thematic clusters at the bottom here. The support log was managed by our MHIN work streams and was used, and we extracted the common forms of support delivered by our team. So we then identified common forms of support, and we then mapped them onto the ERIC profile. As you can see, for the AAOT project, support was requested and offered as needed during implementation or even evaluation phase. We noted that our stakeholder relationships were strengthened, largely during project meetings, and research skills and resources were further utilized during capacity building sessions, for example. We used different methods to make sense of this process. We used a multi-stage mixed method study. For this, we conducted a process evaluation complementing local evaluations as per MRC framework. So the MRC framework recommends using evaluation to understand how implementation works in practice. Our data collection methods include semi-structured interviews, both in person and online. And we also conducted meeting observations, meeting and document analysis, and we're also looking at analyzing or conducting secondary analysis of data. Our data analysis, we used a thematic approach, firstly identifying codes inductively followed by deductive extraction using EPIS, so the exploration, preparation, implementation, and sustainability framework. We would like to point out that during the entire data collection, data analysis phase, our PPI and ETI team have been involved in, for example, developing topic guides, data collection, transcription, and data analysis as well. We have interviewed 49 participants from across our network, conducted a focus group, and observed several meetings, and also looking at document analysis, as I mentioned before. So, early findings from stakeholder interviews have been mapped onto APIS. The themes have been highlighted here due to frequency. This is quite a lot here, so I'll go through each of those phases first. So, firstly, like I said, we've mapped MHIN phases onto EPIS phases. During the exploration phase, this is when the MHIN prioritization exercise was carried out, like Colin described earlier. At the preparation phase, ARC sites were selected. Some project interventions were also selected. During the implementation phase, the delivery of ARC site interventions occurred. And finally, our sites are also thinking and planning for sustainment. Our continued monitoring of data shows consistent themes emerging. For the purpose of today's presentation, we focus on one cross-cutting MHIN theme and one EPIS component. So sustainment is something, like I've mentioned, our sites are thinking about, but one cross-cutting theme is of relationship and communication, which is central to MHIN. Meetings between partner sites and MHIN have been instrumental in establishing a way of working, and this is what some of our sites have mentioned as well. And I'll just go through some of the quotes that from our participants here. For example, one participant mentioned that working between sites has been really helpful. We've had help from working with a partner site as well. At that kind of more inter-site level, help has involved sharing protocols, going through joint meetings, meeting to discuss methodologies, meeting up with various other people in both sites through this MHIN. Our participants did mention that considering MHIN as a network, there was some difficulty with understanding the structure at first, but this changed. I don't think that clarity was there at the beginning, so it created a little bit of confusion about who does what. But once we settled down and we got over that hurdle of understanding, it's been great. And I think you've always been receptive and supportive. So again, I think there's a close relationship here between sites and also between the teams. And then moving on to sustainability, as I've mentioned previously, participants have emphasized the importance of sustainability, but also scaling up what's working. Like participants have mentioned using services in other areas to model what's existing in MHIN. This quote nicely described what participants think about scaling up. It's really important to get that feedback and also to promote the value of assertive outreach approach to make it a more sustainable service, not just for Salford, but that the value of it can be seen and potentially promoted and spread elsewhere. Our participants have also emphasized the importance of communities of practice. I think it's just an organic thing that we just build. And if we keep talking about it, it doesn't create this kind of exclusive club of just these people involved. If there's another bunch of people that would really benefit from it, let's get them involved in things as well. So we know the importance of meetings in promoting all these activities. I will now pass on to Shalini.
Yeah, thanks, Blossom. So as Blossom mentioned, the data analysis is still underway and more themes would emerge, but I suppose it's still fair to say that implementation strategies, the meta implementation strategies, as we call them, they target team effectiveness and may improve adoption and fidelity of interventions such as AAOT. It's fair to say there's a lot of implementation practice capabilities within our partner sites. You must have witnessed that across this webinar. There are also sort of quotes and themes emerging on how implementation PPI and EDI support, which is provided by MHIN, enabled project leads in sort of driving solutions. The other thing to mention for sort of implementation science academics is there's definitely an avenue for sort of advancing the field by understanding how implementation support across various organizations can sort of enable knowledge translation, really. And we'll continue to sort of disseminate these outputs in various spheres in the next year of dissemination. Thank you so much. That's it from us.
Lovely. So thanks very much, Shalini and Blossom, for those insights, and also for sticking to time. So we actually have a little bit more time to give you for a tea break. Thanks to the 100 people who've stuck with us. You can leave your connections on if you like, rather than logging out and logging back in again while you have a tea break. But could we have you back as scheduled at 3:55, where we move from science into lived experience perspectives, which have been really important in shaping this work. So I look forward to seeing you back at 3:55. Okay, welcome back, everyone. Hope you had a good virtual tea break, bit of scones and cream, whatever you had. So now we're moving to some lived experience perspectives, and I'm pleased to introduce Stephen Blood, who is an expert by experience and PPI lead at Greater Manchester, followed by Ruth Bean, who's also an expert by experience, Yorkshire and Humber, and Luke Ingemels, who's the project manager at Renew, Change, Grow, Live in Hull. So maybe I should go first to Stephen.
Hello, can you hear me?
Yeah, fine, Stephen. Go ahead.
Perfect. So if we can go to the second slide, if that's okay. So first of all, I'd like to say this has been a great session already. I think all the presentations I can relate to, so I think it's been really informative already. So I'm impressed. So I wanted to just sort of start with a bit of maybe background about myself. So I used to live in South London. So I worked in Central London, lived in South London, across Lewisham and Greenwich for about 14 years. And I moved to Greater Manchester about 4 or 5 years ago. With the same company that I worked for. And I quickly kind of realized that sort of making friends at my age is maybe not as easy, perhaps, as I thought it was going to be by moving. And quickly started to, I guess, deteriorate with mental health issues initially. So I'd been used to having sort of a London culture where you don't have to necessarily drive home. So every night was sort of in London, going out for drinks after work back in those times. So therefore, I hadn't really realised, I suppose maybe there was a slight problem starting already then. I then, once I was in Manchester, obviously then struggled to make new friends, I suppose I'd call it. And also started to realize that some of the friends that I'd made were not maybe the best influencing people for me. So I suppose then that led on to me drinking at home in Manchester, in Salford, in Greater Manchester, to drinking alone at home more. Which then I now realizing was increasing my anxiety. So I would literally go out, I suppose, to the shop and think, oh my God, I've got to buy what alcohol I can buy. And then I used to come home and think into my flat thinking, oh, thank goodness I'm home. So it's also got worse and worse. I knew there was a problem at that time, and I knew there was a problem with people that were probably influenced me, I suppose, but in my head I knew, but I didn't want to do anything about it, I guess, because I didn't want to leave the house. If I had known, I suppose, at the time that AAOT or assertive outreach existed, I'd have loved someone to come to the house at that point, because it would have been much easier than me going out somewhere. Luckily, I built up a good relationship with my GP in the end. He'd already worked out that there was a problem, it turned out, when I went to him, but it had obviously escalated to a lot more. But I knew at that point that I needed assistance from NHS addiction services, and had had many, not necessarily alcohol related A&E trips, but they'd sort of been accidents, I suppose, that I'd had from drinking too much alcohol at home. So I suppose that gives a little background as to how I then needed the treatment. If you could move on to the next slide, if that's all right. So suppose, like, from that point onwards, I guess my GP did a referral, so I live right on the border between Salford and Manchester City Councils, and my GP is in Manchester City Council, but I live in Salford City Council. So I'm within the GP catchment area, but it doesn't match up with the areas of the services, I suppose. So he initially referred me to Manchester, which I think is changed Live Grow, I think at the time it was, who gave me a 15-week waiting time. And it took, so I just couldn't have waited 15 weeks by that point. So I went back to my GP, and he'd just been presented to by Achieve, which is based in Salford at the time, which still is based in Salford. So he then tried a referral. He'd been presented to that week by chance. He then referred me to them, and they saw me within 2 weeks, but it was in person at that point. So I suppose what I'm saying is that I think I can relate to a lot of what's been presented today in that respect. But I suppose getting involved in this research project, once I'd gone through kind of structured treatment, I suppose I'd call it, I was able to kind of like start to know where to go to get support, or know where to go and do activities, I suppose, if that's the right word to use. I think in terms of how I did lots of kind of like group sessions as well, which was always a big fear of mine originally, like to do group sessions. But actually, once I started it, they were really good, because you can sort of see how you relate to other people, and I think that's really important. I guess in terms of how I became involved in this project, so I've sort of been involved really since the beginning. So I joined a community group, which is run by Achieve at GMMH, and I think the lead for that team introduced me to Dr. Stephen Carr, and right from the outset, I've been involved in this project, and I think it's really given some focus and a lot more understanding of how things work, I guess. And I suppose, like, we have a weekly meeting. I've learned, and I continue to learn so much about how things work. And so I think that's so important, because it gives a bit of focus. So if you feel a little bit down or have anxiety or whatever, whatever the problem, depression, whatever, it sort of gives a bit of focus on knowing a bit more detail. And I think that communication and joint work really works really well. If we could move to the next slide, please. So I feel like I've input a lot into the project, and I can hopefully continue to. So I think there's lots of things maybe that the teams maybe, obviously they know a lot more than I know, but I mean that they, what do I mean? So like, I suppose the teams kind of like have a process to follow, if you like. Whereas I think by being involved in the research and the project, like, it's taught me lots of things, and I've been able to input into sort of my story of things and my thoughts on things, which sort of come from an outside view. And sometimes that's been really useful. Sometimes it's not possible to do, but I think it's so important to have that input, and to get the joined up approach about it. So I think that is really crucial. But I think in myself, I've gained so much knowledge and made so many achievements from my participation. So, for example, I was able to go to a research learning event or course that was held by Professor Karina at Manchester University, where we were taught all about research, and that will benefit me in the future in terms of any job I do in the future, or if I get into that, or whatever. So I think it's just so interesting, and I think at that meeting, at that course in particular, I think there was a real diverse mix of communities in that meeting, which I thought was really, really good, or the course, so it was across 2 days, which really highlighted, I think, there is some differences between different communities, I suppose. So, for example, so I am gay, so I think although the statistics show that there's less of a problem, which maybe there is in problem, if you like, in the LGBTQ community, I suppose it sort of shows perhaps people aren't coming forward or not recognising it, and I suppose more work needs to be done to make it more diverse, I suppose, from my experience. I think it's great once you're in the treatment, but I think it's just maybe knowing about it as well. If we could move to the next slide, please. Thank you. That's really all I'd like to say. Is that okay?
That's more than okay, Stephen. Thanks very much for sharing that with us.
That's okay. Thank you.
Really glad that you've been involved in the project and given us your input. Okay, so shall we now move to Luke and Ruth?
Thanks, Colin, and thank you for Stephen for sharing your story there. Really, that was really insightful, and we kind of just wanted to follow on from that briefly. I'll just introduce myself. I'm the alcohol project manager at Renew Change Go Live in Hull. Obviously, thank you to Tom and the University Hull team for their presentation on the preliminary findings earlier. I think it's really exciting to see the efficacy of this model. And I've obviously today I want some time to introduce you to Ruth. Ruth has been through our service as an expert by experience, and it's been very difficult for us from a PPI perspective within Hull, because obviously this is a very, very new model for us. So we don't have anybody who is an expert by experience within the Alcohol Assertive Outreach model. However, Ruth was a lady who came through our service through quite similar pathway through the hospital setting to what Alcohol Assertive Outreach is now all about. And I think what we wanted Ruth today was to be able to share some of her story, and also Ruth has been a fantastic advocate right from day one with this model as to why we need this within Hull, and Ruth is helping us try and build up our expert by experience insight within the city. So I just want to kind of hand over to Ruth, and she will talk about why she does advocate this model, and it's great and exciting to see that it's already proving that it is working within Hull, and I know Ruth will be someone who will continue to champion the effectiveness of this model. I'll just hand over to Ruth.
Good afternoon.
You might not, some might not be able to speak, I don't think.
All right, okay. My name's Ruth Bean. I've now been dry from alcohol for 2 years, 1 month. I got taken into hospital 2 years ago this March. And I was in a hospital for 5 months. I obviously alcohol abuse, sepsis, COVID, chest infections, but the service that I received from within the hospital was absolutely marvellous. Lots of understanding, support, and guidance. Whilst being in the hospital, I met a man called Derek, who was a hospital worker that went into work for Renew, and he sat and spoke to me, and I said to him, I'll think about it. Anyway, when I got discharged from hospital, I got passed over to Renew, which is CGL, and I was given a nurse, and she was my saviour, and I still say that today. She wouldn't leave me alone. She kept digging and digging and digging, and eventually I agreed to go to Renew. It's the best decision that I've ever made. I was frightened, but when I walked into Renew, the feeling was, well, I just can't put it into words. It was very emotional, and I went into my first group, and I haven't looked back since. I now do 7 groups a week, because my interest now is that I'd like to give something back for what I've been given from the service. There's always support. We've got a safety net. There's always somebody here that you can talk to. I was actually drinking 6 bottles of wine a day. I started off on 1 and it just grew, and it grew rapidly. Yeah, it was a pretty rough time. I didn't wash, like Stephen said. I isolated myself for 18 months, didn't eat, I lost 5 stone in weight. The consultant saw me and told me that I'd got cirrhosis of the liver. I was put on the liver transplant list. I kept all my appointments, continuously going to the groups, because I felt as though I needed them, and I really did need them. And the support that we gave each other was paramount, definitely. I went to Foundations of Life for 6 months, which is where I was really educated about the drink and what goes with the drink, and then offered mutual aid, which I've actually taken up. I'm sitting on the Alcohol 5 group. I've done recovery skills. At the moment, I'm sitting in with Forward Trust that are doing a group here on a Monday. I do 2 smart groups. I also do RSN on a Wednesday morning and Saturday morning, and Thursday night I go to another RSN group. I just won't forget what CGL have done for me, and I want to give back as much as I can, helping people. I feel that I've been extremely fortunate and that I've been well looked after. I'm now not ashamed to admit that I'm an alcoholic. When I was in drinking, it was every other excuse but the real excuse. You know, I had a tummy bug, or I'd eaten something that wasn't right. And I'm now not ashamed to admit that, yes, I do have a drinking problem. And I now know where to go and where not to go. And if I actually get invited to parties, I make a very quick exit before people begin to get rowdy, shall we say. One of my groups, which is an RSN group, we quite often go out for meals, and we do go in the public bars, yeah. But the facilitator that runs that group, when we choose the restaurant, he usually brings up, books a table and informs the pub that we're an abstinent group, and they usually make room for us over the back, so we can't see people drinking from the bar, and it's just to give us an extra safety net, and that works fine. I've met some wonderful people, made some wonderful friends, and today I started my own group, which is a ladies group, because there doesn't seem to be many groups around for ladies. And something came up in one of the groups that I attended about men's group. And I put my hand up and said, well, why isn't there a group for ladies? Because women will speak to women. Anyway, thankfully, we knew have taken that up. I've just come out of my ladies group, and there was actually 6 of us in total. And for the first meeting, that was, to me, that was really good, and we had a good chat. Yeah, and I honestly believe in CGL, and I'd like to help as much as I possibly can if you'll accept me. And that's my story.
Thank you, Ruth. I'm aware, I appreciate we've probably taken a little bit of extra time, Colin, so I do apologise, but I think to Stephen and Ruth, you know, those stories and people with experts by experience getting so involved in helping and shaping and leading these projects is essential. So thank you for giving us that time to share those stories today.
Well, thank you to all of you. You can see from the chat that there's been loads of tributes coming in for Stephen and Ruth, and well done to the teams as well for involving service users in the work. So thanks very much for that. Okay, so we're now moving on to another topic of communities of practice. And this is work that was initiated by Afra Kelsall, who's a senior advisor at the Health Innovation East of England. I think, is that the correct title now? Also we're going to hear from, as well as Afra, Denise Holcroft, who's service manager of the Assertive Outreach team at Big Life Group, and Julie Carey, who's clinical lead at GMMH Trust, who have also been involved in the communities of practice. So happy to hand over to you.
Thanks, Colin. Thanks very much. Yeah, so and Luke, please don't ever feel like you need to apologise for taking time from me so that we can hear from people who've actually used the services and have experience of this. They're the people that we need to hear from most. So thanks so much, Ruth and Stephen. So as Colin said, I'm Afra Kelsall. I was senior advisor in the implementation work stream of MHIN across all 3 projects, but including what we called Project 3, the Assertive Outreach Project. And I'm just going to spend 5 minutes introducing the community of practice model to you, and then I'll hand over to Denise and Julie, who will talk about communities of practice in practice. Next slide, please, Lucy. So when bids were originally submitted for NIHR funding for this research programme, communities of practice were included as an implementation strategy and or a way of supporting implementation. So it was communities of practice were kind of baked in to the research programme, and the funding included the launch of communities of practice. And so I had responsibility for finding out about communities of practice and then launching them. And I was privileged enough to do a leadership development programme that was jointly run by the South London Health Innovation Network and the Health Foundation's Q community. And that enabled me to learn about not only the community of practice model, but also to be able to practice the kind of skills and techniques that are really essential to a successful community of practice. Next slide, Lucy. So what is a community of practice? I think it's a term that's overused these days. Certainly in the NHS, we are invited to attend what are called communities of practice quite a lot, but having learned about what a community of practice is as a theoretical model, many of those communities of practice are not in fact communities of practice. But essentially, a community of practice is a group of people that have a common interest, who gather together to do something that they might be struggling with, or that they might struggle with. They think they might struggle with if they try to address it on their own. So they get together with other people to try and do that thing. Next slide, Lucy. So we can only solve those sorts of problems, the ones that we know we can't solve on our own, if we break down our silos. And in doing that, we talk to people who aren't like us, who perhaps see the world from a different perspective. And we need to seek to share the world from that same perspective and understand one another. So to approach those sorts of challenges that are typically beyond the scope of any individual profession or organisation, we need to share our knowledge and learn together in order to create new knowledge. And that's what a community of practice done well can do. Next slide, Lucy. So this shows what are considered to be the essential components of the community of practice model. I should say that the model that I learned about and that I practice is Etienne Wenger's model, And there are links at the end of this presentation for anyone who wants to learn more about the theory. But this shows the essential components. And often when I'm talking about community of practice theory, I find it easier to talk about what a community of practice isn't rather than what it is. So very often communities of practice turn out to be a management team meeting or a project team meeting or a task and finish group, or just more of an informal network or interest group or friendship group. A community of practice is none of them. It's what you see on the slide in front of you. And the principles that I think are really, really key for communities of practice so that they're non-hierarchical. It's one member, one voice. So no one comes with more power, more status, more expertise than anyone else. Everyone brings their own valued perspective. Membership and attendance is voluntary, and it's collaborative, not competitive. So with the task of launching communities of practice for the programme, I made the offer to each of the projects within MHIN to launch and convene a community of practice for their project. And at the time, projects 1 and 2 were just not in a position to be able to accept that offer for a variety of reasons. But both sites for project 3, the Hull and Greater Manchester Alcohol Assertive Outreach teams were really keen on exploring it further. So Stephen put me in touch with Julie and Denise, who you'll be hearing from later, and we took it from there and launched a community of practice for alcohol assertive outreach. And I'm going to hand over to Denise and Julie to hear about what we did in our community of practice and how successful it was. Thank you, Julie.
Okay, well, that's our first slide, just identifying who we all are. And I'm Julie. I'm the clinical lead over at the High Impact Substance Misuse team.
And I'm Denise. I'm the service manager for the Achieve Assertive Outreach team, which is led by the Big Life Group.
You can pop to the next slide, Lucy, please. Okay, so some of the things that we're going to talk about, Afra's already, alluded to, shall we say, but I suppose we're just going to take you briefly through the journey, which, has been fun. Let's say it that way anyway. It's been a great experience, no question. So I was approached by Afra to begin with, who talked about the community of practice, and instantly, within a very short space of time, everything that she'd just described in her slide just started to really inspire me, tick all of my boxes. It was progressive. It was out of the ordinary. It wasn't about traditional meetings. It was about a flattened hierarchy. It was about sharing experiences and knowledge and growth. And it just appealed to me instantly. And Afra's enthusiasm and knowledge it just seemed the right thing to do. So before we knew where we were, I think we just got taken on a bit of a journey, didn't we? It was like being on the crest of a wave, really. We sent out invitations for probably our first design group, if we were calling them design groups at the time. Denise, I can't remember whether you'll remember if you just turned up or whether you were invited to the actual design group, but we did send out some invitations across our own services, and people who wanted to come and be involved in how we were going to pull all this together got involved. And at that point, Denise, I think that's when you went to your first meeting, isn't it?
It is, yeah. So we kind of looked at, I suppose we were all very new to a community of practice. We heard these words and they did sound inspiring, and we all thought that sounds like a real opportunity for us to look at our shared practices, to look at different assertive outreach models across our teams within GM and Hull. And Hull were obviously a big part of that because they were starting on their implementation of an assertive outreach model. So it just felt like a real opportunity for us to come together. And I suppose the design group as well was our foundation for our learning of what a community of practice is all about, and how we convene meetings, how we kind of change our language style, and it isn't about the management team leading on a meeting. It is about, like Afra said, that one member, one voice, and we really kind of took that by the reins and kind of wanted to, we felt like it was going to be really powerful within our services, I think, didn't we, Julie?
We did. I mean, it was that whole kind of, learning as we went along, wasn't it? So there was never a moment when it felt as though anybody was in the room who knew everything. People were asking lots of questions. We're still doing all of that. Yeah. But I think that what was so useful, and we have to say this, is that Afra had so many tools. She had so many ways of turning this meeting into this gathering of people and minds into something that was a really lovely experience as well. So we knew that what we were focusing on was the work that we were doing, seeing the clients and the outcomes for them as well, and how we could talk about the things that we were finding maybe difficult or challenging, and create an environment so that we could do that, together. So, and we all had a hand in that, didn't we? Like, so to explain the term convening a meeting. So we kind of, the community of practice doesn't talk about chairing. There's no chair. There are people who lead, and that can be anybody. Anybody can lead that meeting. Anybody who feels confident enough to do that. And I think that also the group has definitely done that for people, hasn't it? Built confidence in the fact that, look, we can all do this together. We might be all finding our way, but there's no boss here. That we're all kind of working on a project together, for the greater good, really.
Yeah. So when we kind of started to think about launching the community of practice, that's when we kind of, like you just said, we kind of talked about those shared challenges that we have, and within a community of practice, they are known as our wicked problems. So we talked about, so we got ideas and challenges that staff felt that they were struggling within the assertive outreach projects, and things like closing clients came up. How we do, because we were working with people who have got real difficult problems going on in their lives, and it was how we kind of bring about those closures. It was also looking at how we raise awareness with stakeholders, how we get them to be more aware of the service that we provide and what we do. So within the launch meeting, I suppose we focused a lot around what a community of practice is, and how we want to bring all of our services together. And then we're still at implementation stage of the community of practice, aren't we? We've had 3 meetings so far, and we've at this moment in time agreed to do them quarterly. So we bring the teams together on a quarterly basis, but we're still meeting within the design group meetings around about every 3 weeks, aren't we, to ensure that we keep the momentum going, and we keep that shared objective in terms of what we want to bring to our community of practice. And then our last community of practice that we held just last week, which was our 3rd one, it just felt like it was a bigger opportunity for us to focus a bit more around the wicked problems that we've talked about, rather than kind of revisiting what a community of practice is. We felt like we've implemented that into our community of practice, so we were able to focus on those wicked problems and look at those challenges, and see if we can bring about some solutions or just some shared learning that people have had within their different services and different models of working as well. So it just feels like it's picking up momentum as well, and there's a bigger understanding now of what a community of practice is.
And what I also loved as well, when we explored all of these things with APRA, was it wasn't just about finding solutions. We go into meetings, don't we, thinking we've got to develop an action plan. There's got to be this solution. There's got to be people who are all drawn in to get to this end game. And really, if your end game is sharing knowledge and understanding and switching on light bulbs for people, and creating inspiration and looking at alternative ways of doing things, and starting from positions of, yes, we can do this, rather than thinking of all the blocks in the way. And so that really emerged for me, and felt that was a very inspiring thing for me, that we're not just action planning and task force doing, that this, you know, this is about growth for the people who are working in the services, and also for the people that we're serving as well. So definitely inspiring, everybody throwing into the pot their thoughts and ideas and experience, and a forum that you just wouldn't have alternatively, would you, anywhere else, you know? So
I think
then we did talk.
Sorry, Julie.
I was going to talk about the participants thing as well.
Okay, yeah.
Go on.
I was just going to say as well, I think it's worth mentioning that one of the biggest challenges, we've talked about funding throughout today's, and I think one of the biggest challenges or wicked problems that we kind of came across within creating our community of practice was around bringing experts by experience into the community of practice, and the challenge that we found was the funding aspect in relation to people coming and giving their time and us being able to financially support them with that. And that was one of the main conversations I think that we've had throughout our design group meetings, and then we discussed it at our community of practice that we had last week as well. So I think if there's any ideas or opportunities where we can look to raise more awareness to incorporate that funding into the community of practice, to bring more experts by experience into the group as well.
And also, I suppose, whilst we're working there out in the field, you know, helping people understand what it is that they're getting involved in as well. So now we all know it's a message that we can spread, isn't it? We just need to be able to source some funding in order to be able to put our money where our mouth is, really. So is that about it, or is there anything else that we want to say? I think it covers most things, doesn't it?
We've kept you as best time as we can, Colin. Oh, you're on mute, Colin.
Thanks very much for sticking to time, and I'm very grateful for that. And thanks to Afra and Julie and Denise for sharing your experiences of communities of practice, which I think has been a really positive thing for the whole project, actually. Supporting each other and sharing your knowledge and learning, and trying to solve problems collectively, which I think is, you know, really important. And as you say, it's not something that's often available to teams when they're setting something up, or even when they're trying to sustain projects. So thanks for that. Now, I know Afra has to leave, but thanks very much for joining us today, Afra, and for all your work on the communities of practice, which has been really greatly appreciated. What I'd like to do is to bring everybody back on camera, if I may, so we can have our Q&A session. Okay. I think most people are back. Good. So we haven't actually had a lot of questions in the in the Q&A function. So if you do have one, now's the time to fire away. But perhaps I could just kick off with one, which is just to ask Amy, Tom, and Stephen about their sort of reflections on each other's presentations and what they found, particularly around the outcomes for the work. Would you like to go first, Amy, and just sort of give us any reactions you have to that?
Yeah, sure. So, I mean, quite a lot to take in. I'd actually like to sit down and look at it all again, because there's a lot of similarities, but a lot of development of the work that I think we had just sort of started to look at as part of my own earlier work on the trial. It was very interesting to see, and very rewarding to see them being implemented in local sites, and to hear some of the more specific information that can come out of those local audits and the qualitative work. I was very interested, in fact, in hearing more about the not only the qualitative work with patients, which of course there's a crossover between all three, but I think we were very keen to speak more with practitioners and stakeholders, but didn't quite manage to include that in our work. And of course, that's vital for implementation purposes. So it was exceptionally good to see all three of those groups included in the local qualitative work. It's really interesting. And I think Stephen talked quite a lot about fidelity, which is I mean, it's obviously very important, but interesting also to see ways in which that is true to the original severe mental illness models, and in which ways we can deviate to be more specific for our population with alcohol dependence. And I think that one of the things that was coming through in my work was very much the fact that a lot of that care can be provided within the service itself, as opposed to more of a care navigation kind of earlier model. So the specific team components that also Tom talked about, and about the staff growing into the role and really becoming exceptionally passionate about what they were doing, and just getting the right people into those jobs, was all very similar kind of findings, I think, from what we were looking at.
Thanks, Amy. Tom or Stephen?
Yeah, I mean, just to kind of echo, I guess, some of those things that Amy said, I wrote down when you were talking, Amy, about the patient-led agenda and advocacy and care navigation. And I think, I mean, I don't want to speak for Denise or Julie, because, you know, they're running these services, but it sounds like there may be variations in fidelity to the model. But I think one thing that's true to all these teams is that they're excellent patient advocates, and really take care to help people navigate what are incredibly complicated medical, social, psychological systems. And I think, obviously, we as academics get quite preoccupied with fidelity, but, you know, there is a reason for that, because I think you can get a bit of mission creep, can't you? And you can sometimes be a victim of your own success. And there is something about thinking about who the core group of people that you want to serve is, and making sure that services are sufficiently resourced for that. I think one of the things that I brought up quite a lot in our talk is sustainability, because unlike the service in Hull, our services aren't new, but they're certainly valued, and we seem to be seeing evidence of effectiveness in our preliminary examination of the data. But we certainly, that doesn't mean that they're not at risk of not experiencing further funding cuts. So I think that that's something that really came home in our analysis, and I think something that we need to consider going forward. Some of the other things I wrote down kind of relate to some of the things that Shalini and Blossom were talking about, which is that it's been super helpful from our perspective to have people from the central team, but also Karina as well from Manchester, who have experience in, you know, implementation science and learning about the CIFR and proctors. I think you can actually apply the CIFR, proctors, ERIC criteria or EPIS to all kinds of situations and services. And I think what we've learned here in GM, actually, off the back of this project, is that that actually a lot of the data we've generated could be replicated in other services in order to improve outcomes and patient experience. And I think the thing that's sort of missing from some of our current analysis is that interaction between the AAOT teams and structured care. So we'll be looking at doing some focus groups with our structured care teams to really look at that interface between AAOT and traditional alcohol care services as well. But yeah, that's kind of it for now. Thanks.
Okay. We have a question in the Q&A about I'm not sure who it is, but be interested to hear more about the new AOT service in Hull, working with the Mental Health Trust in terms of changes to pathways that were there before. So maybe for anybody in the provider team, comment on sort of engagement with mental health, because you emphasised quite a lot about the engagement with the acute trust, but I wondered if there was a sort of link up with the mental health.
You want to pick that up, Luke, or?
Yeah, I'm happy. And sorry, you put on the Q&A that you're happy to pick that up, so I'll pass that to you if you're okay too.
Okay. Yeah. Okay. Yeah, I suppose structurally we have a strategic group in Hull which works with all providers around developing pathways. So that's been fundamental from the sort of very beginning. We did, as part of the development, engage with the Mental Health Trust senior management around setting up and developing the pathways. But I think fundamentally there's good relationships between CGL and the trust through dual diagnosis workers. That's been very useful, and also the relationship with psychiatric liaison services in the hospital. And what's kept that on track, I think, is our regular fortnightly meetings that have been ongoing with the commissioners who oversee the pathways. And those fortnightly meetings have been going on throughout the whole of this last year, haven't they, Luke? So we've had an opportunity to tweak, support, and I suppose problem solve any pathways that have emerged.
Yeah, and I think just to quickly add into what Tom said, I think we've reflected that, and I know it's one of the key components, I think, to some of the success that the frequency of those meetings being fortnightly, and the attendance within them has been from lots of stakeholders has been very well attended on those regular basis. I think that's been really key, because any problems that we've had, anything that we've had to try and iron out within the process and the system, we've been able to do so sort of quite quickly. And there was a time where we talked about reducing the frequency of the meetings, and actually that was decided as a group that it wouldn't be beneficial, that we still felt the benefit of meeting fortnightly. So I think it's a real this model has really strengthened working with partners in the city, and I think it'll hopefully be something we tap into for future projects, because it's been really effective from day one.
Thank you. We have another question from Shaheen Edu about gambling, and to what extent the services encounter gambling as a comorbidity, or manage gambling as a comorbidity. I don't know if Julie or Denise, you want to talk a little bit about that, or is that something you've come across in this group?
I think we do, and I think it's something that's definitely discussed when we're meeting with people. I suppose it's a difficult one to respond to. We do look at the networks that are available and in and around our communities for people to gain support with gambling addictions, but we do find that a lot of people that we work with as another issue that they may raise with us is the fact that the debts that they have to manage alongside their addiction is also something that's identified. So it's not something, I suppose, that we would manage in-house. It's more looking at those community networks, which is why I think it's imperative that as an assertive outreach model, we ensure that we do link in with all the community support that's available for service users, to ensure that they're receiving all the relevant support. Don't know if there's anything you wanted to add, Julie.
I mean, I'm not familiar. Yeah, I've only been around here for a year, and it's not something that's cropped up within our team. But again, just like any other addiction or issue or social problem or whatever it might be, that's the nature of what we do. We link people in, we support them to get there. We do all of that work, don't we, to support people and link them into the right service. Yeah. Thank
you. There's another good question here from David Henstock, who asks, often services are lost due to lack of evidence that you're working hard to develop. As we don't typically have the research infrastructure behind us to prove efficacy, what tips can you give us to protect the services we have and know are good but struggle to evidence? I don't know if our evidence specialists would would like to talk about that. It's obviously a lot of the developments take place outside of research settings, but often the commissioners are looking for evidence. I don't know, Shalini or Blossom or...
Yeah, I can come in. I suppose that's an excellent question. And when we were trying to sort of prioritize interventions for this network, quite a few interventions which actually seem quite promising couldn't be picked up because we were more interested in sort of picking up interventions such as assertive outreach, which have some clinical effectiveness evidence, or sort of they chime with the needs of the population, but also have some implementation sort of readiness evidence, so to say. Well, to answer your question, it's a difficult one. One could always also conduct service evaluations. So the results of service evaluations are mostly used to generate sort of information that can be used to inform local decision making within the trust. So sort of that's one way to go about and sort of get buy-in from your local HINs, health innovation networks, and sort of academic health science networks, and yes, essentially sort of try to tap into existing networks which are sort of trying to do similar work in other sort of universities, and be aware of system actors and the sort of upcoming research. So essentially, I'm saying it's generally very difficult to get onto that research ladder. And also, the other important point is, even if you get clinical effectiveness evidence, there are numerous papers saying how there's a 17-year gap from getting an intervention from the shelf to the trust. And so another sort of good way of tackling that is doing sort of hybrid design. So you're looking at implementation evidence and research evidence together and trying to sort of close that evidence to practice gap. I hope some of it sort of answers.
Yes, that's very helpful. Tom, do you have anything to add to that? I know you've been sort of very involved in service delivery, but also evaluation, and you seem to have managed to get quite good traction with your commissioners in Yorkshire and Humber. So what's the solution there?
What's the solution? I think building relationships is really important. Trusted relationships on presentation of the positive outcomes of studies, and also recognizing where there's paucity of information or poor outcomes of studies. I think building that trusting relationship across commissioning providers and perhaps with the university, we've been able to develop a partnership approach around our strategic boards, where I think it's becoming more apparent that the commissioners sort of want to work with providers in supporting the development of services such as AAOT, 2-year contract, 3-year contract, or whatever, but on the basis it's going to be evaluated. And I think that seems to be creating a mature attitude to allowing services to develop and not hit the ground and get KPIs that sort of fire off and are very positive, but allows services to mature. And I think that's essential, that relationship in this type of study or this type of service model, where it is very unique and does require a lot of nuance around the service model. And that change from moving away from motivational models to actual engagement and working in with patient-led agendas is really refreshing. So we're very, very positive about a relationship in Hull and East Riding, actually, and want to do more of this research-led commissioning, really. We see it as a partnership with the university.
Yeah, and you've also had good links with your clinical research network in Yorkshire and Humber, so they're actually already wanting to roll this out to other parts of that region. Absolutely. On the basis of your findings. So that's all positive. Yeah. So building relationships with key strategic partners seems to be quite an important lesson. I wonder if Steve and I could ask you a little bit more about patient involvement in research and particularly this project. So yeah. I mean, we know from the presentations that we've seen from Tom and Stephen, and also from Amy, that a lot of the patients who are going to be helped by this intervention are actually not in a very good place when you initially identify them and try to engage them with services. So I just wondered what kind of challenges you've had doing that in Manchester, and if you've got any sort of tips for any of us.
Well, I think one thing that we did
Sorry,
early
it was
in Manchester.
Stephen Blood. Sorry, I forgot there were two.
Oh,
Steve.
sorry. Oh, thank God. Over to you, Stephen.
We can hear from you as well, if you like.
Yeah, I think there's lots of challenges to overcome generally, in the sense of, obviously, the person, I suppose, has got to want the help in the first place. So I guess, or the patient has to want the help. And I know from my experience, it's kind of like you deny it for a long time until it gets to a point where you can't deny it anymore. However, I was lucky I built up a relationship with my GP to be able to go and ask for the help. I think a lot of people are isolating potentially themselves in their homes and need someone to go to their home, really. And it's sort of, if they don't know the service exists, or if it doesn't exist in some areas perhaps, then it's like knowing who I suppose to contact, I suppose I'd call it, until it gets to the point of them probably having to start an ambulance for them, which unfortunately then ends up with the person in A&E, I guess is what I would say.
Right, that's really helpful. Sorry, Stephen, other Stephen, to cut you off in your prime. Go ahead.
Yeah, I was just going to say, one of the things that we're quite lucky about in Greater Manchester is we've got somebody called Sarah Jane, who's our community lead. And so she was really helpful in helping us set up this addictions research huddle, which is actually how Stephen and I think, met for the first time, wasn't it? It was through Sarah Jane. And we held events.
It was through Sarah Jane, yes.
Yeah, and we held 2 events. Initially to kind of prioritize, to sort of test ideas that the research group had with service users, and then a second event to sort of prioritize things. And so that allowed us to help get service users involved from the get-go. And then that was already up and running as we set this project up. So we were kind of ahead of the game, really. And then we also, I have to say, benefited from Karina and her approach, and this course, or these 2 study days that Stephen talked about as well, because that was run in such a way that allowed us to recruit 2 people who had been through the Alcohol Assertive Outreach team to get trained up in research, and also to contribute to some of the PPI work as well. So I think, the tips are to kind of get in there early and from the very beginning of the research, and also to offer these, training courses, because I think they're hugely beneficial. And, we've benefited massively from having Stephen on our weekly meetings. Long may they continue.
Thank you very much.
Sorry.
Yeah, and I mean, Amy, your presentation was interesting in that it wasn't purely about economics. You're also talking to patients and asking about their experiences. I mean, what's been your experience of trying to integrate, hard-nosed health economic data with patient experience?
It's been quite experimental, and I think it's, well, just in sort of methodological terms, it's not something that we had seen happen much before. There's quite a lot of qualitative work embedded within clinical trials, but not so much necessarily to sort of really home in on the aspects of the intervention that are feeding into cost effectiveness, which happily, obviously, we found. But certainly in terms of wider, I mean, work with patients is certainly something that I've always been very involved with anyway. So it was an essential for me to factor in the qualitative work to the economic evaluation from the start. And I think it's been really helpful actually just to focus our minds a bit more on exactly what we're asking patients and why, and it's hopefully, I think it has helped to provide some extremely focused information on what feeds into not just the effectiveness but the cost savings and the differences in service use. So real great insights, and I could have talked a lot longer about that.
But you seem to have some convergence between, you know, what the patients are saying help them and how it impacts on the economics or the costs.
Yeah, absolutely, and especially again,
the hospital admissions reduced, but the question is, why are they reducing? What are the key things that are making that change possible? So that's where I think it's really valuable what you've got there. There's another question has come in about what about under 18s, and maybe I could sort of broaden that out and say, well, what about other potential addiction groups that might benefit from the assertive outreach model? I'm thinking, you know, high risk drug injectors or, you know, other groups of people. But Tom, I know you're interested in developing work around young people. What are your thoughts about this model for young people, or indeed what is available for young people?
Yes, we're particularly interested in this area because the data sort of supports that the vast majority of people in need of substance misuse problems and mental health are sort of not engaged in any services and really in contact with youth services mainly, or A&E. And we need to think much more creatively around their sort of potential needs in ways of identifying individuals. So it seems to be a sort of, if we can work up ways that we can identify people with complex problems, it probably has some potential benefits in terms of not only working as assertively for young people, but probably with their families. They're likely to be relatively small in number with very high needs and complex problems, but they've probably got sort of ingrained social problems and structural problems with families as well. So I think we're certainly keen to sort of begin to do some developmental work around this area to profile young people, particularly with sort of complex areas of care and needs, criminal justice, conduct disorder perhaps, and also think about how acceptable this type of model might be to them. So I think there's quite a lot of developmental work to be done there, but there's clearly the underlying prevalence suggests that the numbers are there to sort of work with people, and they're very much a hidden population who are sort of unfortunately bouncing around the sort of health and social care settings. So we certainly would like to adapt something like this in that area.
Okay, thanks, Tom. The clock is ticking round, so I think I probably ought to just say a few final things. The recording of this session will be available on our ARC South London YouTube channel, and I think Michelle, Lucy, you'd be able to send a link through to the delegates when that comes. You'll also, I guess, be publicising it more widely, and also the slides that went with the presentations. I think we're going to be able to distribute those to people who attended and possibly put them up on the ARC South London website. Just better check with people first if they're happy for all the details of unpublished stuff to be put up there. We also would like feedback from delegates, and I think we're going to have a little form. There it is, it's come up in the chat, so if you could click on that and give us your feedback, it helps us to refine and improve sessions like this. Also, over the next year, as I said, we're going to have, we've been granted a funded extension by NIHR, which will allow us to do a lot more dissemination work and engagement with regions in the country that have not been involved with the project so far. So if you would like to be involved in the future, please let us know. You know, we've got a list of people already who we know are interested in the project, but we're always keen to add more people to that. We're wondering about how we might extend the communities of practice. We're wondering about what kind of outputs would be useful to people. So it'd be great to have people from more parts of the country involved. Okay, I think just finally, I have to say this was a great seminar today. So well done to all the speakers for all your contributions. And it's been great to have such a variety of talks, you know, from service user perspective to data science to practitioners on the ground. And, you know, it's not often you have a webinar that spans all these different moving parts of the machine. So thank you for that. Also thanks to the organisers, Lucy and Michelle from ARC South London Comms team, and Lucy, who's our project manager on this project. Thanks so much for organising it and making it run so smoothly. Thank you to all of you who are attending the webinar and giving us your questions. And please do keep in touch with us. I can see there's a lot of specific sort of requests for contact and further engagement have come through in the chat and the Q&A. So we'll be following those up if we haven't already said we will. You know, particularly people in the same region who would like to connect, for example, or learn about, you know, how they could do this in their local area. So that's really what it's been all about. Hoping you've enjoyed it today. I certainly have, and thank you all for attending. Goodbye.
Right.